Good morning and good afternoon. My name is Monica Pica. I'm with Sachs Healthcare, and I will be your technical producer for today's webinar. Firstly, on behalf of Baxter and Sachs Communications, we want to thank all of the frontline workers in our audience for your commitment and passion in helping all of us through this very difficult time. We are truly indebted to all of you. I also want to show our audience how you can send questions in throughout the webinar. Please see the Q&A tab to the right of the player where the content-related questions can be entered, and our speakers will try to answer as many questions at the end of the presentation as time allows. For technical assistance, please use the Tech Support tab directly to the right of the Q&A tab. Also, please find there the Handouts tab. You can download the handouts at any time. And our moderator today is Kathleen Volman. Kathleen is a critical care clinical nurse specialist, educator, and consultant. She has published and lectured nationally and internationally on a variety of topics, including pulmonary, critical care, prevention of healthcare acquired injuries, work culture, and sepsis recognition and management. Ms. Volman was appointed to serve as an honorary ambassador to the World Federation of Critical Care Nurses. Welcome, Kathleen.
Oh, good morning or good afternoon, everyone, depending on where you are. And thank you, Monica, for that very kind introduction. The title of today's webinar is Getting the Fluids Right, Case Studies Using Stroke Volume Technology to Personalize Management. And I'm very excited to introduce our two exceptional speakers for today, Nicole Kupchak and Angela Craig. Nicole is a clinical nurse specialist and independent critical care consultant. She is the former chair of a Code Blue committee and as well as a sepsis coordinator. She has authored 6 certification review books and numerous published papers. She's a contributing editor for AJN's EKG Strip Savvy and a national and international speaker. Our second speaker today is Angela Craig. She is a critical care clinical nurse specialist for the ICU at Cookeville Regional Medical Center in Cookeville, Tennessee. She is a sepsis coordinator there, and she also serves as advisory on the advisory committee for the Sepsis Alliance Group Sepsis Coordinators. She has lectured extensively for numerous conferences and webinars on sepsis and hemodynamic topics, and she's published on a number of topics on sepsis and heart failure. I want to put a sponsor disclosure. This program is sponsored by and on behalf of Baxter Healthcare Corporation. The speakers have been contracted by Baxter Healthcare Corporation to present this material on behalf of Baxter. And our speakers do have some disclosures. Nicole Kupchak's disclosures are a consultant and speaker bureau for Stryker Medical and Baxter Healthcare, and Angela Craig's disclosures are consultant and speaker bureau for Baxter Healthcare and Edwards Life Science. I'm happy to say this educational activity is approved for one contact hour, and a link to obtain CE credits will be available at the conclusion of the webinar. And the webinar is supported for this educational activity by provided by Baxter Healthcare. And I'd like to turn it over to Nicole to get us started.
All right, well, good morning, good afternoon, everybody. We're super excited that you joined us. I cannot believe for 2,500 people signed up for this webinar, so this is pretty cool. Now, I hope most of you were able to catch the first webinar. So this is a 2-part series webinar. In the first webinar, we went through the literature behind fluids, behind stroke volume changes with the passive leg raise test. We talked through how to do a passive leg raise test. Now, in this webinar, what we're going to do is I'm going to do a quick recap of the literature, and then we're actually going to go through 2 cases. And just a warning, well, let me actually go through the objectives and I'll give you kind of the wording. But we're going to talk about how nurses, RTs, physicians, advanced providers, nurse practitioners can drive practice change at the bedside for fluid management. We're going to apply a lot of the critical thinking and literature that we learned in the last webinar to cases. And hopefully this will really just drill down the information and it all makes sense. Now, in this webinar, we have 9 polling questions. Now, I will tell you, this is unheard of. This is a lot of polling questions. So what I want you guys to do a couple things. I want you to, first of all, make sure that you're not on full screen, because if you're on full screen, you're not going to be able to see the questions. So just please make sure you're not on full screen. And then what you'll notice is to the right of the slide, you'll see the polling questions themselves. Click on the answer that you think is correct. Do not put your answers in the comment section. Okay, so with that, let's start with our first polling question. So here we go. So I would love to know where you all work. So are you at the bedside as a nurse, doing critical care, progressive care? So if you could start your answers at any point. Are you a respiratory therapist? Are you an educator? Are you a manager or director, a clinic spec? Are you on the rapid response team, transport? Or maybe we just don't have your position listed. So answers are rolling in pretty quickly. And so this poll, I'll give a little bit more time, but in the following polls, we're not going to give as much time because it's very, I'm hoping you'll get the answers quick because they're all clinical. Okay, so I'm going to finish up the poll in 5 seconds. And 3, 2, 1. Okay, let's see what we have here. So it looks like the majority of the people on the line are respiratory therapists and then nurses. We've got about half and half between RTs and nurses. And then there were about 15% of you in the other category. So we'll have to figure out who you are on the line here. So, okay, I'm really excited to have all of you. So again, this is Fluids 2020. And I think so often clinically, we have this whole idea of, we've got a sick patient. Let's give them fluid and then we'll take it off later. Yeah, no big deal. We'll just give as much fluid as we need to, as much as we think we need to, and then we'll just pull it off later. Well, but there's problems with that. There are a lot of side effects and a lot of detriments to over-resuscitating. There are detriments to under-resuscitating. So the questions we have to ask is, when do we give fluid? Which fluid do we give? How much fluid do we give? And what is that patient's response to the fluid? And we covered a lot of this in the last webinar, but we're just going to do a quick recap. I want you to start thinking of fluids as a drug. Would you ever give insulin without knowing the patient's glucose? The answer is no. And so the question you need to ask yourself is, if you're giving fluid, what do I want to see? And some of you might say, oh, I want to see the heart rate come down, or I want to see the blood pressure go up. And maybe, but actually if you dig into the literature, heart rate and blood pressure are very poor predictors of fluid responsiveness. What I want to know is, if I give fluid, what happens to that patient's stroke volume? Does their stroke volume, does their cardiac stroke volume increase when I give fluid? If so, that's the right time to give fluid. But if their stroke volume isn't going to increase, then I really need to back off the fluid. So let's do a quick recap of the literature from the last webinar. So which fluid to administer? So these were 2 studies, SMART and SALT ED trials, that evaluated over 29,000 patients who are from the ICU and non-ICU. And what it demonstrated was that saline led to a higher incidence of acute kidney injury. So what are the issues with saline, that we've given for decades? Well, it's very high in sodium and chloride, and we're thinking that the hyperchloremia leads to the kidney injury through renal vasoconstriction, and also can lead to significant acidosis. So, and this is just, again, a side-by-side comparison of saline, lactated ringers, and Plasma-Lyte A. And you can see, really, if you look at our own plasma and physiology, Plasma-Lyte A is probably the closest to our own plasma. Whereas you could see the pH on saline and LR is actually, saline is 5.5, so it's very, very low, and then LR is 6.75. But again, the big problem with saline is that big chloride load that we give patients, when we administer the fluid. So from that SMART ED and, from the SALT ED and SMART trial, what they did in that trial is they did a secondary analysis specifically of septic patients. And they looked at the differences in outcomes between those who got saline and those who got lactated ringers or plasmolite A. And what they found was that the patients who had sepsis that got saline had higher 30-day mortality. They had a lower incidence of acute kidney injury within 30 days. They had a greater number of vasopressor-free days, and they got less dialysis, and they had more renal replacement therapy-free days. So again, this just, even in the septic population, there was a mortality difference when saline was given. And so in sepsis, one of the things we know is that fluid choice matters. It absolutely matters. So there were a lot of questions from the last webinar. So what I did was I picked up kind of the repeating themes of questions that we didn't get to and wanted to address them here. So this was a question that came up quite a bit from the last webinar. Does giving lactated ringers increase potassium levels? Because that's one of the big concerns, right? So in a liter of lactated ringers, there are 4 milliequivalents of potassium. Now, the thing you have to understand, so does giving LR increase potassium levels? The answer is no, it doesn't. And the reason is that a patient's potassium volume of distribution is much larger than the extracellular compartment. And what happens is there's equilibration. And there were 2 studies actually demonstrating when they gave LR, it actually lowered the potassium level. So does LR increase the lactate level? And the answer is no. The lactate that is in LR is sodium lactate. It's not lactic acid. So it's not the same lactic acid a patient produces when they're hypoperfused. So the answer is no. LR is not going to increase the lactate level. So isn't LR incompatible with most other IV fluids and medications? And the answer is, we're not really sure because saline was studied over and over and over again. And I will say this is an area that definitely needs to be explored. It's not that we know that LR is incompatible, we just don't know what it's compatible with. So again, this is going to be a major area of study. So are the Surviving Sepsis Campaign guidelines going to change how we give fluid and which ones to give? And the answer is stay tuned. I was just on a webinar last week, and it was announced that the Surviving Sepsis Campaign guidelines are going to be published after the first of the year. So stay tuned to see if they make recommendations specifically about fluid. So what about the 30 mils per kg? If we've got data to say the patient doesn't need the full dose, what do we do about that? And again, I'm hoping that will be addressed in the Surviving Sepsis Campaign guidelines. Okay. All right. So, and just a reminder, how much fluid to give? Well, if we give too little, we know there could be some major issues with altered tissue perfusion, renal failure, circulatory collapse. And I think that maybe that was a problem years ago, maybe when I first started as a nurse in the early 90s. But really, the problem we see clinically is that we give way too much fluid. How many of you have taken care of a patient who looks like the Michelin Man or the Michelin Woman? We all have. And I think we've just gotten to say, that we just kind of accept it. Of like, it is what it is. That's just how it's going to be. But actually, it doesn't have to be that way. We can get the fluids right. And we're going to talk about how to do that. So this is, again, a recap of the KU study that was published in 2017. It was a before and after observational trial that was retrospective in nature. And they evaluated fluid guided by a stroke volume change versus usual care. In usual care, this is my own word where I say air quote guessing, right? So they're using things like heart rate, blood pressure, and lactate levels to decide if a patient needs fluid. And basically what they were able to demonstrate is when stroke volume was used to guide fluid resuscitation, patients got less fluid. And I think one of the things we took from that study is it's not just about giving less fluid, but it's giving fluid at the right time. You want to give fluid when the patient is preload dependent and their stroke volume is going to increase because of that fluid administration. So in general, when stroke volume was used, patients got less fluid, they had spent less time on vasopressors, their mechanical ventilation needs were cut by 51%. That is insane, 51% reduction in mechanical ventilation needs, and then their ICU length of stay was decreased. Then from that, so there was a strong signal there to say, oh, there was a major difference in using stroke volume to guide fluid responsiveness. So from that control trial that has ever been done using stroke volume to guide fluid versus usual care. There has never been another study done that was set up like this. It's a very challenging study to do. It's called the FRESH trial. And we just got the results 2 months ago of the FRESH trial. And basically, what they were able to demonstrate in this randomized control trial is that when a stroke volume measure was applied in the emergency department in septic patients and carried through, they found that they gave less fluid. So you can see the 72-hour fluid balance. There was a statistically significant decrease in the amount of fluid that was given in the treatment group, and I think this is key, is again, just nailing when is the time. We have to identify that time in the patient's presentation when they're going to be fluid responsive. Now, something that just keeps showing up in the literature over and over and over again is that there is this subset of patients after they get that initial fluid administration are no longer fluid responsive. But clinically, often we keep administering fluids without understanding that. And I think this is a reason to use some sort of a stroke volume measure. So some secondary endpoints of the FRESH trial were that you can see statistically significant difference in renal replacement therapy needs. I mean, this is a big difference. And if you think about just the financial impacts of this, I even just think of the socioeconomic impact of this. This is massive. Other things, again, they were able to demonstrate less mechanical ventilation needs, and that was statistically significant. So that whole concept of load them up now, take it off later, it doesn't work well, as you can see with the lungs and the kidneys. The kidneys do not like, or the lungs do not like to be fluid overloaded. Their ICU length of stay, although it did not reach statistical significance, there was a 3-day difference when a stroke volume measure was used. I want you to think about this. 3-day length of stay decrease. That equals a major, major financial cost avoidance. And then discharge home, again, you can see most patients were discharged home versus going to extended care facilities and rehab when a stroke volume measure was used. And again, the reason is that we're just not massively over-resuscitating these patients. So going back to the KU study, that was that before and after study, they were able to demonstrate a cost avoidance of $14,500 on patients when a stroke volume measure was used. And I think, just that in and of itself is enough. It just kind of gives you some power to say we need to stop guessing on fluid administration. Less intubations is going to equal less chest x-rays, less ABGs. If we're not damaging the kidneys, that's going to equal less dialysis. And this all ends in major, major, major cost avoidance. Okay, so we're going to kick it off with our first patient scenario here. You've got a 58-year-old who presents to the ED with a productive cough, fever, and chills. They get admitted to acute care. So in the ED, the patient got 2.5 liters of fluid. They got IV antibiotics. We got blood cultures before the antibiotics. A lactate level was done, a CBC was differential, and procalcitonin level. And vital signs, so this was after they got their fluid, heart rate's 106, the MAP is 60, so that's still not really where we want it. So this patient's on acute care now. At this point, they're on acute care unit. Their oxygen needs ended up increasing from the ED to acute care. Now they're on a 50% mask, breathing 26 a minute. The temperature is 38.6. The lactate was 3.2 in the ED, and so it got rechecked on acute care, and it's 2.8, which is still a bit elevated. Not a bit elevated, it's still pretty elevated. And then the procalcitonin level was 2.1, which is, it's elevated, but it's kind of in that gray zone. So based on all of this, so we've got a fast heart rate, they're hypotensive, oxygen needs are increasing. What I want to know is, what do you want to do? So I'm going to launch the poll. And I want to know, what do you want to do? So given all of that information, do you want to give more fluid? Do you want to start norepi? Do you want to start dopamine? Do you want to give dobutamine? Give fluid and norepi? I'm not sure. So what would you like to do? So get your answers in. Again, we're just going to give you a few more seconds here to get your answers in. Answers are rolling in pretty fast. Okay, and what did you all say? So a lot of you said, so I'm going to publish the answers here. So a lot of you said, let's see, I'm not sure. I actually think I'm not sure. If you were on the last webinar, you know that I'm not sure is actually an okay answer. So, but about 12% of you said give more fluid, and then about 12% of you said fluid and norepi. And I think the bottom line is, I think I'm not sure is actually a really okay answer, because we don't know. Because again, when you give fluid, what do you want to know? I want to know, does their patient's stroke volume go up? And nothing I gave you was measuring stroke volume. Okay, so I'll just tell you, we ended up giving more fluid. So we gave another 500 cc's of fluid. So now the patient's gotten 3 liters of fluid. Heart rate's 105, MAP is 63, their heart rate's 22, and the temp is 38.2. So 2 hours later, the patient's lethargic with decreased urine output. Heart rate's up to 112 now. The MAP is down to 56. So we know this patient's getting in trouble. Respiratory rate's back up to 26. The fever's going up. Call a rapid response. We get a lactate, and the lactate's 3.4. Ha! The 3.4, I don't know. What do we want to do next? So how many of you have ever been in a position where you've got a hypotensive patient, maybe they're on acute care, maybe they're in the ED, and you're trying to decide, do I give more of this, meaning fluid, or do I start this, meaning a vasopressor? Because if I start this, the vasopressor, where does the patient have to go? The ICU. And we all know that that is a massive barrier to starting vasopressors. So what we ended up doing was putting a device on the patient that measures stroke volume. So we used the bioreactance device. And with this device, you put 2 electrodes above the heart, 2 electrodes below the heart. You kind of make a box around the heart. And these top electrodes will send out kind of a signal, and the bottom electrodes will interpret that signal in a couple of different phases. And it will measure stroke volume. It'll measure cardiac output. And then we can index both of those numbers. And then it's also going to give a measure called TPR, which is total peripheral resistance. And basically, you think of that as the patient's afterload. So if the TPR is low, I'm assuming their blood vessels are vasodilated, whereas if the TPR is high, I'm assuming that their blood vessels are vasoconstricted. So we're going to use this device with the passive leg raise test. So we're going to sit the patient up, head about up, legs straight, get a baseline stroke volume. Then we're going to drop the head and lift the legs for about 2 to 3 minutes. And if the stroke volume goes up by 10% or more with that leg raise, the patient's likely going to be fluid responsive. But if I lift that legs and after 2 minutes the stroke volume doesn't go up and the patient's hypotensive, then I'm going to start a vasopressor. Now I want to remind you, you wouldn't do this unless there's a sign of hypotension or hypoperfusion. And this patient is definitely hypoperfused. So we're back to our patient, and pre-PLR test, you can see, again, they were hypotensive. Stroke volume is 122 with an index of 72, so that's pretty high. So I'm thinking my patient's hyperdynamic, but the TPR, that total peripheral resistance, is 540, which is really low. And so I'm thinking they're hyperdynamic, vasodilated with low blood pressure. Okay, so we lift the leg. And this is what happened after the PLR test. So after the PLR test with the legs raised, their stroke volume went from, index went from 4.6 to 4.7, and the stroke volume went from 122 to 132. The index went from 72 to 78. So basically, the change in stroke volume with the passive leg raise test was 8.3%. So given that the patient's hypotensive, I'm trying to decide fluid pressor, which way do I go? I did the PLR test. The stroke volume change was 8.3%. Given that, what do you want to do? So here's our next poll. I'm going to launch our poll and would love to know what you guys think. The stroke volume index change was 8.3%. So how are we going to treat this hypotension and hypoperfusion? So your answers are rolling in super, super fast. Patient's hypotensive, I've got to do something. The hold tight is not a good answer. They're hypotensive, I've got to do something. Don't answer hold tight. I see some of you are saying hold tight. Don't hold tight. They're hypotensive, right? We've got to do something. We've got the rapid response team here. Okay, so we're going to finish the poll and see what you all said. All right, so the poll is finishing in 3, 2, 1. And you said, most of you said start norepinephrine. And that's completely appropriate to start a norepinephrine infusion. We need to start norepi because the patient's hypotensive. We did the Legre's test. The stroke volume change was only 8.3%. So that is predicting the patient is no longer preload dependent and will not be a responder to fluid. So they're going to third space. If I give this patient a liter of fluid, they're going to third space all that fluid. So we obviously now we've got to go to the ICU. So we start an norepi infusion at 5 mics per minute. We titrate up to 10 mics per minute. And you can see the MAP is 73, lactate's down to 1.5. The stroke volume index is 66. So they're still pretty hyperdynamic, but you can see the total peripheral resistance is a bit better, and then they're not as vasodilated, which makes sense if you're giving a vasopressor. So given these numbers, what should we do? Well, so you have to ask yourself, is that patient hypoperfused or hypotensive? And the answer is no. Their MAP is 73. So what should we do? Let's hold tight. That is the best answer, is to hold tight for now. So again, should stroke volume be the sixth vital sign when you've got these patients who you're trying to decide fluid pressure, like which way do we go? And I honestly think, the evidence is there. We need to start using a stroke volume measure to decide if a patient needs volume. So with that, I'm going to hand over to Angela Craig, who's going to go through another case. She's going to show you their protocol at Cookeville Regional, and she's going to go through a much more complex case. So, Angela, you ready?
All right. Thank you, Nicole. So what you see on your screen here is one of our cheat sheets. I love to give cheat sheets to the nurses, and feel free to plagiarize. We share this so that you can have this information. But notice what Nicole was just speaking about. Is the patient hypotensive or hypoperfused? And there's our algorithmic approach to how we handle that. So she's already talked about that. I'm not going to repeat it all, but notice whenever you're given those fluid boluses, whether you give a fluid bolus or a better choice, in my mind, if we're able to do a passive leg raise, so that we can really determine, are they going to respond. This next picture is the back of our cheat sheet, and basically it gives all the just the correct answer, what the actual normal range values are. It also shows you that Bellamy curve and the Frank-Starling curve, so feel free to use that. But I have another question for you guys, and we're just going to do this really quickly. Are you able to initiate non-invasive hemodynamic monitoring based on your patient's clinical condition? So are you able to do that? And I'm going to get this started for you, and feel free to answer just really quickly. Just curious to know, yes or no, are you able to do this? And the answers are coming in quickly. All right, I'm going to stop this in about 3, 2, 1. I've got that about 63% of you guys are able to, so that's excellent, and about 38% are not. What I really want to encourage you to do is to be able to have some kind of a nurse-driven protocol to where it allows you the ability to do this on your own. And here's a sample. We've got critical care standing orders for patients who come into my ICU. The providers can negate this, but most of the time they don't, because these make a whole lot of sense and save the providers some time. So there's one statement in there on our hemodynamic monitoring that says if our patient is hemodynamically unstable, that we are able to go ahead and initiate that on our own. I literally was making rounds yesterday and spoke with one of the nurses. We had a liver failure patient, and he just looked pitiful, and he was hypotensive, and the nurse was like, we're giving him some albumin. I said, I think that would be a good patient for non-invasive hemodynamics. So the nurse went ahead and placed it, and then we're able to collaborate about these results. So I think it's very, very helpful. So I'm going to start with the next scenario, and this is a 48-year-old man who came in from the emergency room into our ICU and did have septic shock. His issue was a blockage, a UTI is what his diagnosis was, due to his blockage from a kidney stone. He did have a fever. He was given Tylenol down in the emergency department, but he also had a history of heart failure, so he's got an ejection fraction of 35%. So as you all know, everybody's really leery sometimes to give fluid to these patients, and rightly so. We want to know how well they respond individually. Well, in this patient, they did go ahead and he needed to be intubated. They did do lactate blood cultures, and we did that 3-hour bundle down in the emergency room. He did receive 30 mils per kg of fluid and got the broad-spectrum antibiotics in the emergency room. So you can see here that the patient's MAP was low at 57. He was febrile. Heart rate was elevated at 120. He did have a very high lactate at 12. His white count was up to 26,000, BUN 20, creatinine 2.6, and the patient had a high procalcitonin. So we decided to do non-invasive hemodynamics. Once the patient arrived in the ICU, we connected them. We obviously want to better optimize. So what we wanted to do was to get baseline. So our pre-PLR numbers are stroke volume of 38, and that is low, cardiac index of 2.5, TPR is 600, so that's a little low. Temperature is still high, heart rate's still elevated, and our MAP is still low at 57. So we went ahead and did our passive leg raise. And after the passive leg raise, let's look at what we got. So our stroke volume only increased by 1. So we went from 38 to 39. You guys, it's simple math. When you do that, 1 divided by 38, you get 2.6% increase. So as we know, based on our algorithm, usually if you're volume responsive, we want to see about a 10% response. Cardiac index stayed the same. TPR came up just a smidge. Heart rate is still elevated, and we're still hypotensive. So we definitely are hypoperfused and hypotensive, right? So that's when, and we knew that before we did our passive leg raise. So based on our post-PLR numbers, let's do a polling question. So based on these clinical findings, what do you think we should consider next? Should we give vasopressors, norepinephrine? And I'm going to go ahead and publish these for you. Based on our clinical findings, here we go. Do we give vasopressors, norepinephrine? Do we give an inotrope, dobutamine? Do we give more fluid? Or do we give a vasodilator? Vasopressor, inotrope, fluid, or vasodilator? And I'm going to move quickly. Here we go. We are finishing this up, and I'm going to go ahead and publish this for you guys. I had that 75% of you want to give norepinephrine. Excellent. And we're going to go and explain why we would not give more fluid. Remember when we talked about our volume optimization strategy, we want to tailor this to every patient. And notice our stroke volume only went from 38 to 39. So we did not have a 10% increase. So fluid would not be our choice here. Now, when you think about why we would give norepinephrine over an inotrope, I know this patient has a history of heart failure, but remember, you guys, our patient is vasodilated. Look at our TPR, and we all know that if we give a positive inotrope, we may dilate him a little more, and this patient is already hypotensive. So we know we're hypotensive, we have a low TPR. This patient, yes, needs norepinephrine. We need a vasopressor. All right, so based on our clinical findings, let's make sure we're all going to be on the same page and give that patient a vasopressor. All right, so we started our norepinephrine infusion at 5, and we increased that. This patient stayed pretty sick, was a very sick patient, and we did increase that fairly quickly over that next hour based on our hospital guidelines, and we ended up at 20 mics. And by the time we get to about 20 to 30 mics, the reality is that they're probably going to need something else added to their regimen. So we knew that, hey, what else could we do? Now, the one thing I want to remind everybody, and I'm going to mention, so pre-PLR, stroke volume is 46, cardiac index 2.1, TPR 675. Our temperature did come down a bit, so that's good, and our heart rate came down a little bit, but our mean arterial pressure is still low. Right? So we're still hypotensive, we're still vasodilated, and our stroke volume is still low. So our question would be, is the patient still hypotensive or hypoperfused? And we've already answered that. That answer is yes. So of course, what do we want to think about doing? Absolutely, everybody, we want to do a passive leg raise test. So we're going to do a passive leg raise test on this patient, and our results are the following. Stroke volume went from 46 to 48. Remember, you guys, I teach my staff, it's just if they're 46, think about moving that decimal point over. We need to increase by about 4.6 or about 5. And so you can tell very quickly that this is not a 10% increase, right? My cardiac index went down a bit, and my TPR stayed the same. And you can see heart rate is right around 110, but we are still hypotensive. So yes, we're hypotensive, and we are hypoperfused. So the next question I'm going to ask you is, what do you think we should do now? Should we, based on this clinical information, what should we do now? And so let me just click to that slide for you. Here we go. Let's go ahead and vote. What would you like to do? Would you like to increase your norepinephrine? Would you like to add another vasopressor? Would you think about giving a positive inotrope, or give more IV fluids, or give a vasodilator? And I'm just going to tell you, I really don't want to see a vasodilator because this patient is already hypotensive and is already, as you can tell by that TPR, a little low. So they're already dilated somewhat. Okay, I'm going to finish this poll in 3, 2, 1. Let's finish that. I will publish that for you. I had some of you that want to increase the norepinephrine. Majority of you want to start another vasopressor, and I would agree with you. Inotrope some of you, and give more fluid a few of you as well. So let's go back to and review this. So what we suggest is that we would start another vasopressor, and vasopressin be in that second line. Now, the rationale behind that, stroke volume 46 to 48. We did not have a 10% increase, right? And our cardiac index is actually going down. So I know those of you who suggested inotrope, I know that's what you're thinking about. But remember, we dobutamine, those patients can vasodilate even more. We already have a hypotensive patient, so we really want to be careful, and we're going to try this second vasopressor. All right, so we added vasopressin at a set rate, 0.04 units per minute, and our pressors did continue. Blood pressure improved for the next hour. Our MAP was greater than 65, and our TPR improved as well. Our lactate decreased to 5. We're still elevated, but we're real happy that it's decreased. And after about an hour, my cardiac index dropped from 1.9 and my stroke volume decreased. So you can see here, stroke volume is down to 40, cardiac index down to 1.9, but my TPR is about 900. Temperature's much better, heart rate's much better. My mean arterial pressure, thank goodness, is still 66 though. So let's think about what we might want to do next. And I hope you all thought, hey, let's do a passive leg raise. And the reason why I want to mention the importance of this, we can't just continually think about adding agents without considering, do they maybe need volume? So this is where that passive leg test can be so incredibly helpful. And we did a passive leg raise, and you can see what happened here. Stroke volume went from 40 to 42. Everybody, simple math. It needs to be an increase in 4, right? And we're only an increase in 2. So we know for a fact that that is not a 10% increase. Cardiac index is still low at 1.9. Heart rate's good, and our mean arterial pressure is still decent. We're kind of at that lower end of what we want to see, but it's still decent. So what should we consider? So I'm going to let you guys choose based on this clinical information. What should we consider next? What should we consider next? And I'm going to start that poll for you. Feel free to go ahead and vote. Should we increase the norepinephrine? Should we give another vasopressor? Or should we maybe start a positive inotrope, dobutamine, or should we give more IV fluids or give a vasodilator? And we're going to be very brief because we want to give you the opportunity to ask any questions. All right, and 3, 2, and I'm closing the poll right now. And I'm going to publish that for you guys. And basically I'm seeing that many of you want to increase the norepinephrine. Some of you want to start another vasopressor. Some of you want to start a positive inotrope. The majority of you do. And give more IV fluid. Some of you would like to do that. But let's talk about why we would not give more fluid. In fact, our choice definitely would be the one that the majority of you guys picked is dobutamine. So remember, you only give fluid if you have a 10% response in stroke volume, but you only give that if you are hypoperfused or hypotensive. We know we're hypoperfused here because we have a cardiac index that's very low. So we need to think about what we can do to help perfuse that patient. We are not going to give another vasopressor because look at their mean arterial pressure, everyone. Why would we give another vasopressor if their mean arterial pressure is fine? All right, but we do have that low cardiac index. I am worried about that patient, so we are going to add dobutamine. And we know we don't give fluid because they did not have a 10% response to stroke volume. All right, so we are going to and I think I snapped a little quicker. Here we go. We gave norepinephrine, we've got vasopressin, and we've got dobutamine that is continuing. Our cardiac index improved as well as an increase in stroke volume. So we are going to hold for now on that scenario. All right. So now we have this patient that has a stroke volume of 40. And 1 hour after we gave that dobutamine, so we were fine for an hour, but notice what happened with our stroke volume. We have an increase in 55 for our stroke volume. Cardiac index is 2.5, and you can see heart rate's going up a bit, and then you can see that our mean arterial pressure is 68. So we are happy with the fact that with the increase of dobutamine, we have increased our stroke volume and increased our cardiac index. Now, it's been 2 hours, and our dobutamine, after we started that dobutamine, you can see that now our blood pressure has dropped. And this is so common, right, in our ICUs. Our patients do not just stay beautiful for long periods of time always, and this is the beauty in this, using bedside hemodynamic monitoring. So 2 hours after this dobutamine was started, our blood pressure dropped with a MAP of 56, and our stroke volume dropped to 50. So we are hypoperfused or hypotensive, aren't we? Based on that, what do? We're already at 30 of norepi, a 0.04 of vasopressin, and dobutamine. Now, we want to know, hey, will volume help this? So what are we going to do when we're hypoperfused or hypotensive? You got it. We are doing a PLR. So we're going to do a passive leg raise, and when that passive leg raise was done, notice what we found. Stroke volume went from 50 to 57. Is that a 10% increase or greater? Absolutely. Simple math. It's only 5 greater, and this was 7 greater. Cardiac index went up. TPR went up a bit, and you can see heart rate just went down a little bit, but our patient is hypotensive. So based on this information, you guys, what are we going to do? Let me select that question for you. And what are we going to do? So based on that information presented, What should we consider next? Are we going to increase the norepi? Are we going to add yet another vasopressor? Are we going to add another inotrope? Are we going to give more IV fluid, or are we going to give a vasodilator, or are we going to hold tight? We are going to, these answers are coming in. Lots of people, yay! I'm seeing what I want to see. I'm going to publish this so you guys can see it. I am showing that majority of you definitely want to give more IV fluid. That is excellent because your patient had stroke volume increase of greater than 10%. So we are going to absolutely give more fluid. So even though that patient was so sick, after we had up-titrated him on the appropriate amount of vasopressors and all of those meds that we were on, notice this patient did then respond to fluids, and that's what that patient needed. So you can see here that after we gave our fluid bolus, you can see what then happened. You can see post-PLR and then after we gave our fluid bolus, and you can see what happened. So we're going to ask yet another question. Based on this clinical information, what should we consider next? And I'm actually just going to move forward just so that we can do this a little quicker. The patient was given, we decided just to hold tight. And the reason behind that is our stroke volume, you can see here, it's 63. Our index has come up beautifully. Our TPR is elevated a little bit more than it had been. And this patient's mean arterial pressure is 71. So what you've done here is you've really individualized the care for that patient beautifully. So here is an overall scenario of this patient, and you can see as we initiate and as we give medication and or fluid and what our stroke volume response is, you can see how we have tailored our care specifically to this patient. Now, some final thoughts regarding that scenario. Remember, stroke volume optimization can make a tremendous difference in how we care for our patients. I have seen this firsthand. Guessing or basing our next steps on heart rate and MAP, that definitely can lead us in the wrong direction. And we want to take the time to evaluate patients' individual hemodynamic status. And we know that can help us to individualize that care and help us make the best choices. And I think that's what we all want to do with all of our critical care patients. And with that, I'm going to hand this back over to Nicole.
Yeah, so well, thank you, Angela. I think that was pretty awesome. That case was super complex. You can see how that patient went from being volume responsive to not, then needing positive inotropy, and then needing fluid again. And I think that's one of the key things is so many times we'll start a vasopressor or we'll start a positive inotrope, and then we just get in that lane and just keep increasing those drips because they're running, right? When really, sometimes when you increase the patient's stroke volume and cardiac output, they can then later become fluid responsive again. And I think that case was just a nice highlight, especially in the setting of heart failure in their history. It can be so complex to understand what the patient will be respond to, and that's why, or that what they will respond to, and that's why stroke volume, I think, is just such a great measure in these patients. But again, we want to thank everybody. We're going to take some questions. We made sure to finish, so we had lots of time for questions. But just again, to wrap things up, you have to think of fluid as a drug. Fluid overload or fluid underload, they're not benign. Fluids are not benign. The type of fluid is not benign. And you really need to put some thought into what we're giving patients. But again, just think of fluid as a drug. And I really am hoping within the next year, we all start looking. I honestly feel like this is a time where technology can really help us so that we can stop guessing on fluid administration. And stroke volume measures can definitely assist in optimizing fluid without major complications of under or over resuscitation. All right, so with that, I'm going to hand it back to Kathleen Bowman, who's going to give you some information on attaining your CEs, but she's also going to be she's going to be posing the questions for all of us to answer. And I've been looking at your guys' questions. I'm really excited to answer some of these. So Kathleen, you ready to hand it back? Kathleen, I think you're on mute.
Thank you very much. Sorry about that. Awesome job, Nicole and Angela. Those case studies were really comprehensive and very thought-provoking. Before we begin the Q&A, as Nicole talked about, I wanted to remind the audience that this activity is approved for 1 contact hour, and how to get that is to go to SacsTesting/RB. You'll need to register at the test site and complete the evaluation form. And upon successful completion, RTs and nurses will be able to print off that certificate. On top of that, this and the previous webinar will be available on demand at www.right/balance.org. And an email will be sent to all registrants when it's available. And the on-demand version will also be accredited for nurses and respiratory therapists. So let's get to the questions. All righty. So I wanted to ask some questions around the whole PLR and fluid responsiveness. Despite a patient not being fluid responsive, using the NICOM, some providers still want to give fluid if the lactate has increased or is still elevated. Your thoughts on that, and also maybe how to talk to the provider about that?
This is Nicole, and I can just go ahead and pipe in and say, I think that's a common thing. And what I've seen clinically happen so many times is that you've got a patient who still has an elevated lactate, and you're giving fluid, or you're being directed to give fluid to treat the lactate when the patient's no longer fluid responsive. And I mean, the patient's just going to third space that fluid. And I think that's where you have to ask yourself, does this patient need a vasopressor if they're hypotensive, or do they need positive inotropy? And when I ran a sepsis program for years, and one of the things I can tell you is so many septic patients had our right ventricular dysfunction. And the thing is, you don't know unless you go looking with an echo. And I will tell you that once we started looking at their patients, especially the right side of their heart, we started giving more and more dobutamine. And I think that's the key, is ask yourself in those cases, if their lactate's not clearing, they're hypoperfused for a reason. But if they're no longer fluid responsive, don't give more fluid. You've got to ask, what are the other things I can do to improve that hypoperfused state? You can start a pressor if that's indicated, or look at that heart to see if they need a positive inotrope. Angela, is there anything else you would add to that? Because I have just seen so many patients get over resuscitated just to treat a lactate, and it's just maddening.
Absolutely, Nicole, and you are exactly right. I currently chair our hospital sepsis team, and that is exactly what we're seeing as well. A fair amount of these patients take a hit cardiac-wise and might need a positive inotrope. So you're spot on.
So there was a couple of questions by Corinne with regards to what is the difference between stroke volume and the 10% change and stroke volume variation to see if your patient is a fluid responder after a PLR.
Yeah, I can take a first stab, and then Angela, please add to this. So one of the things you have to remember, if you're using stroke volume variability or pulse pressure variability, is there's a lot of rules. And the rules are, you have to be intubated on a tidal volume that's anywhere from 6 mils per kilo to 8 mils per kilo or less. You have to have a closed chest. So there's a lot of rules to using stroke volume variability. If the patient meets all that, they're intubated, they're not overbreathing the vent, they're on a tidal volume that's lower. If they meet all of those things, then use it. By all means, use it. But I think that's the problem, is that, especially as a patient I presented to you, that patient wasn't intubated and they were on acute care. They went from the ED to acute care. So that would have been not even an option for us. But if you've got somebody in the ICU who meets all of those criteria, then by all means, use it.
Yeah, and I'll pipe in here too, Nicole. Rarely do we have patients that meet all those rules in our ICU. And so I really encourage my staff to go more with stroke volume optimization. That seems so much more appropriate for the patients in the ICU. Now, in the OR setting, I've used SVV in those cases down there, but they meet more of the rules versus ICU. So hands down, I would recommend stroke volume over stroke volume variation in the ICU setting unless they meet the rules, which is going to be rare.
So just to be super clear, we're talking about stroke volume changes with either a passive leg raise test or by just giving a small bolus of fluid over a very short period of time. So yeah, I completely agree, Angela.
And Nicole, it was great that you brought that up because Elizabeth asked the question, is PLR better or the same as a 250 ml bolus?
Oh, can I speak to this? So
yeah.
I really prefer a bolus, I prefer PLR over a bolus because you have to then, if they do not respond, how are you going to pull that off? And so this is a great opportunity if they have the ability physiologically to have a PLR, hands down. It's the way to go because when you lower their legs, you're going to remove that volume, right? So that's my vote. What about you, Nicole?
Yeah, it's interesting. You know, I've been following this literature for a number of years, and it's like oddly there's something kind of magical in the PLR test. And it's easy, and if you've got, oh, well, my patient's heavy, because I'm wondering if kind of that's where some of the questions are going too, like this is hard to do. But, I know we got pretty crafty. We had a pillow made up that you could lift the legs up on, or you can use your overhead slings. So there are ways to lift the legs that aren't completely back-breaking, but think about this. If you've got the right patient, meaning they don't have a DVT in their leg, they've got both legs, they don't have an unstable spine, so if you've got somebody whose legs can be lifted, there's no harm in lifting their legs. Whereas if I give a bolus of fluid to see if they're fluid responsive, again, that all adds up over time and can cause harm.
That's great. One of the questions that dovetail off of this, and they talked about, is the change the same as the 10%, looking at stroke volume as a 10% change in blood pressure when you do a PLR? Because a lot of people think they can use blood pressure, right?
Yeah, there's just plain and simple, there's no correlation. Now, I will say, there is something newer. It literally just got published, I think it was 3 or 4 weeks ago, where they tested, it's called the diastolic stroke index. And it's where you take the heart rate divided by the diastolic pressure. But, it's just, again, there's so many limitations because we know heart rate and blood pressure in and of themselves are not predictive of fluid responsiveness. But, stay tuned, on the diastolic shock index. But right now, I think one of the best things we have clearly from the data is using a stroke volume measure to guide fluid responsiveness.
So one of the questions is non-invasive hemodynamic monitoring active in AFib? Is it accurate? Sorry, not active, accurate.
Yeah, so we use, absolutely, we're able to utilize this in the AFib population. Once again, I think maybe where they're going with this, there are some rules with SVV, and I know on those patients with the SVV mode, but for us, most of the time we're utilizing stroke volume, so we utilize it in our AFib population as well.
Great.
Yeah, and just to clarify, the SVV, what we're referring to is stroke volume variability, and that would be, and another device would be pulse pressure variability, but those are arterial line technologies. And to use the variability of stroke volume or pulse pressure, that's where all of those rules come in that we talked about, where you have to be ventilated, not over breathing, and a certain tidal volume, closed chest. So, so just to make sure that that's really clear. But the technology, I know that I showed you guys that we use on the patient, it doesn't matter if they're an AFib.
Now we're reaching close to the top of the hour, and we have a lot of questions. I want to get one last question in, and then Monica, I'll turn it over to you. Is there ever a time when you would stop giving fluids, even with a greater than 10% increase in stroke volume? I had a patient that they were 5 liters in and are still hypotensive, but having a greater than 10% change in stroke volume, it just seems like a lot.
You know, so basically, physiologically, the patient's telling you that they'll still be responsive. But you know what I would have done with somebody like that is I really would have looked at the CPR to see, and their diastolic pressure, just to get an understanding, like, is this patient massively vasodilated? Because if they are, I honestly probably would have asked to start a vasopressor with it.
Yeah, I agree 100%. And then, this brings up that point, Nicole, that is so important, that people may still respond, but if they are not hypoperfused or hypotensive, do we need to give it? And so a lot of us live on the upward portion of our Frank-Starling curve. I think back years ago, we used to kind of say we would give it until they quit having a response. But the reality is, if we have fixed their hypoperfusion or hypotensive, it sounds like in that case they had not, but absolutely would look at that TPR and look at where that patient's at. Could we add something to that?
That is great. Thank you so much. You guys have been phenomenal. These questions are great. I know we didn't get to all of them, but I tried to get groupings of questions that would answer the majority. So I'd like to turn it now back to Monica, our moderator.
Thank you. And this does conclude our webinar for today. I would like to remind the audience that there is a survey for you at the conclusion that will pop up immediately, and we would greatly appreciate you sharing your opinions today on this webinar. And we thank you again. And on behalf of our presenters, Sachs Healthcare Communications, and our sponsor, Baxter, I hope you enjoy the rest of the day.